This is actually broken up into 2 lectures because there's so much material here. But let's just see how far along we get. And again, as I said, a lot of this is review. A lot of it is pretty simple and straightforward. So we'll sort of blast through it. And I'll sort of point out the highlights of what I think is really important. You know, on the pediatric side of hearing loss, most common of the birth defects, which someone commented about on the blog there. You know, the current estimate, it says 3 to 4 per thousand here. I think the national estimate's about 2.2 per thousand, and roughly 1 in 1,000 have severe to profound hearing loss. So those are your cochlear implant candidates. And it's being better understood that this doubles by school age. So, you know, late onset hearing loss is being recognized more and more as a major problem, and we really are not doing a great job screening for that. So there's a lot to learn there. I just think this is an interesting slide just to put it in perspective. You know, you can see that the incidence of hearing loss is vastly more common than all the other major birth defects, but because, you know, we can't see it, people don't recognize that it's there, and so it's something to really keep in mind there. You see the incidence of it relative to and the impact of this is something I think conceptually is we have to keep in mind as otologists, is that when you impact on hearing in children, you end up with difficulty in speech understanding, which impacts negatively on language development, and then educational impacts. John Naparko and his colleagues actually looked back at this. It's probably over 15 years ago, but the lifetime costs were estimated at $1 million at that time, of which most of it was related to lost earning potential. And the sad fact is that still only in the United States, somewhere on the order of 40 to 50% of kids that are cochlear implant candidates are actually getting the device. So that's a sad fact, and that's a lot better number than you see for adults. And it impacts, as we said, sort of education and employment opportunities. So I'm just going to move forward. This is sort of a classic paper from Schildroth and Karchmer, which was published a number of years ago, but it looks at reading equivalence, which the red line is normal hearing kids, and the blue line was deaf, untreated, uncochlear implanted kids, and it looked at grade equivalence for reading ability, and the sort of the typical number that people talk about is reach a 4th grade reading level by 18 years of age. So really pretty bad stuff, and similar stuff for earning potential. So the answer, of course, as we all know on the pediatric side, is to identify these cases early, make a careful diagnosis, both from the hearing perspective, sensory neuroconductive, severity, as well as on the medical side. And I'll try and make a case for why the medical diagnosis really matters. And then intervention, which is should be family-centered, should focus from our perspective on providing a good signal, whether it be amplification or a cochlear implant or even sign language, so that they develop language of some sort, and making sure that they get that information in the right window, which is as early as possible, really. And then obviously, you know, the educational aspect, which is also key. This is a good website. It's run by Carl White at Utah State University, and it's this infanthearing.org. It's actually funded by the federal government through the EDI programs federally, and I encourage you to go on and look at this website. It has a lot of good information on screening. The new JCIH statement is actually out now. You can find it in the journal called EDI, EHDI, JEDI actually, and it talks about sort of it's sort of a Bible for understanding newborn screening, the details of programs and data capture, and then also medical and other intervention strategies. So I encourage you to look at that. It's no longer in pediatrics. We had some issues there. So, and then on the adult side, this is the big opportunity. We were talking earlier, I think Brandon and I were talking about, you know, adult hearing loss. You know, 40 million people in the U.S. have it, so it's just ultra common. Many of them are related to either noise-induced hearing loss or presbycusis as they get older. And the diseases that we commonly see in our clinics, Meniere's and sudden deafness, acoustic tumor, those are really uncommon relative to the other. It's very common that people that leave the military end up with tinnitus and hearing loss. Those are the two most common symptoms. So super ultra common. And on the adult side, instead of the speech and language thing that we think about in kids, we think about communication abilities and detrimental effects on quality of life, which turn into things like social isolation, depression, cognitive acceleration. Frank Lynn's done some really nice work there, and so really a sort of a different feeling problem than the pediatric front. The pediatric is sort of on the developmental upswing, and then the adults, of course, are sort of later in life and more concerned about quality of life issues and keeping employment. The adult population, the number is about 7% of adult candidates are actually getting cochlear implants. So if you want to go into practice to do cochlear implants and you want to do a bunch of them, start on the adult side because there's a huge opportunity there. The pediatric side is sort of labor intensive, lots of people involved, smaller numbers of cases from a surgical standpoint, much more developmentally driven and educationally driven. And then you look on the adult side, it's sort of the converse of that. Actually, I have a slide here on it. So you think of the pediatric practice as sort of personnel heavy, well-defined population off of the newborn screening. You can think of it, as we talked about, developmental and educational benefits, and then adults sort of on the opposite side of that. I think the adult practice is going to become, over time, much more sort of like we see stapes surgery and other hearing interventions. I think as we simplify the mapping processes and all the post intervention follow-up, I think it's going to become more and more simple. I suspect it'll even become more sort of done online as time goes on. So, and the answer, I think, for both adults and children is, as we talked about before, identification, diagnosis, intervene, and educate. So this is one of the most important slides I'll show you, and you'll see it again later when we talk about auditory neuropathy. But the key factor is that newborn screening needs to happen early. It generally should happen before they leave the birth hospital, and newborn screening should be finalized by the end of the first month. So the JCIH talks about a 1-3-6 rule, which means that screening should be finalized by a month, sort of making an official diagnosis by 3 months, and intervention starting by 6 months. So when I say screening should be finished by a month, they might get it in the hospital. If they fail, they need to undergo a rescreening and sort of be done with their screening process by the end of a month and be referred on. And then diagnosis is based off of, for the most part, ABR and ASSR. And as long as they don't have auditory neuropathy, they usually can have hearing aids fit very, very early on. We'd like to get the medical evaluation to happen at the same time. So in the very perfect world, if a baby really fails and they come for a diagnostic ABR, it's really a nice time to try and link together sort of a medical evaluation. You can sort of do it on the backside, but it just starts to add more time as things go on. So in the perfect world, medical evaluation should happen in the first 6 months or earlier. And early intervention, that's a term that's thrown around. All of us here listening to this lecture think of intervention as putting a cochlear implant or putting in tubes, but in slang terms, early intervention really speaks to diagnostic and speech therapy. So when you hear the term early intervention, this is the SLPs talking about intervention in the form of speech therapy. And then usually by 6 to 9 months of age, the child is old enough to do VRA and behavioral testing. So you would confirm the ABR results with behavioral testing sometime in the latter half of the first year, usually right around 6 to 9 months, and then start, if it's a no response ABR early and you're also seeing behavioral testing that's confirming that, you could start to think about a cochlear sometime between 6 and 9 months. Diagnostic speech therapy should be coming along and showing a lack of progress as well. And then you can think about implantation usually between 10 and 14 months. This is the absolute perfect sort of timeline, but I would tell you that no more than 25% of the kids fit into this timeline for a variety of different logistical reasons. So sort of imprint this on your brain. This is how you should be thinking about it. So when you think of kids, that show up and they failed their newborn screen and haven't had an ABR and they're at 6 or 7 months of age, things are way out of whack. And it's just important to keep this timeline in your mind. Are there any questions thus far?
Yes, I want to ask you if the ABR is compulsory as part of the screening, because in Argentina, the screening is only autoacoustic emissions.
Yeah, really good question. I'm glad you brought it up. So when we talk about screening, we're talking generally about automated technologies. And when I say an automated technology, it means that you put the ear tip into the ear, and then the machine runs in an automatic way and gives you a readout. So there's two technologies that are used in screening, both otoacoustic emissions, which for the most part are distortion product otoacoustic emissions, or automated ABR, AABR. And that's to be contrasted with ABR used for diagnostic purposes. So when people talk about a screening, they're talking about automated technology. When they're talking about diagnostic, they're talking about using a typical ABR machine where they look at multiple frequencies, multiple stimuli. They usually identify thresholds and give you a good idea of which hearing aids can actually be fit off of a diagnostic ABR. Does that clarify?
Yes, thank you so much.
Yeah, sure. Matt?
Yeah, when in this whole process do you typically like to get your imaging work up? Because I know some people advocate to get it early on so you have more of an idea what's going on, or others will wait till that year mark when you're really considering the CI and getting all that going.
Yeah. Yeah, I don't actually see any value in waiting, because, and we talk a little bit about it later, but for the most part, MRI is more appropriate than CT in children these days. And if you identify a child who has, say, a profound hearing loss and no cochlear nerves, just as an example, that's a very different child than a child that has a no response ABR and has normal anatomy. It just changes the way the family thinks. It might change the way that you intervene. And so generally speaking, we do it early as possible. I don't think we need to do it at a month, but if it's possible, I'd like to do it with the diagnostic ABR if it's being done for confirmatory reasons, if the ABR is being done for confirmatory reasons. Otherwise, I usually do it certainly before 6 months.
Thank you.
All right. Yeah. Yeah. It's a common question. And usually I don't get any CTs, none, except in rare instances, and we'll talk about those later. All right. Good questions. So the otolaryngology perspective is obviously to classify hearing loss with our audiology colleagues, but also put some anatomy to it. So sensory neural versus conductive, understanding if there's otitis, those kind of things. Better understanding an etiology, which requires some understanding of genetics and whatnot. We make a lot of referrals to professionals based on what else is going on, but obviously the speech and language pathologists have to be involved, audiology colleagues, other developmental pediatricians, psychologists and whatnot. And then, in the early days, which is our first 6 to 12 months, we're usually, aside from that evaluation that we're talking about, we're thinking about tubes if they have lots of fluid. Occasionally, if a child has a big conductive, we think of osteoconductive, like softband, Baja, or whatnot. My 2 cents on tubes is that recognize that the guidelines for tympanostomy tubes are for kids that do not have sensory neural hearing loss. If you have an underlying sensory neural hearing loss, the guidelines mean nothing. And so generally speaking, I have a very, very, very low threshold for putting tubes in that have an underlying sensory neural loss so that you can get to the intervention that's necessary, whether it be hearing aids or a cochlear implant. So my threshold for putting tubes into kids is very low. To wait a long time, I mean, I spent many years taking the whole watching and waiting approach to kids with fluid in their ears, and the next thing you know, you've spent the first 2 years, working around otitis episodes, and they're not getting their cochlear implant because they have, refractory or recurrent otitis media. So I just have a super low threshold for that, really very early on. So etiology matters for these reasons. You know, a lot of people ask. I think even someone on the message board when we were going back and forth early about sort of genetic testing, and you know, etiology matters because it might identify another medical condition, for instance, like Jervell and Lang-Nielsen, Alport syndrome, Usher's. There's a condition called Brown-Violetto-Van Laer syndrome, BVVL. It presents as auditory neuropathy, and it's treated with riboflavin, which is basically a vitamin. And if you don't treat it, the child has progressive neurologic demise and can actually ultimately die. And so, and their only presentation at the beginning is basically hearing loss and auditory neuropathy. So super important, obviously, for these examples of identifying. Now, they're all not really common, but for instance, Usher syndrome that results in blindness. That's worth knowing in the first year, while the visual loss will come on over years afterwards. It would be super important to recognize if a child's going to have Usher syndrome so that they don't go off to learn sign language. You know, that would be something that could be devastating for that family. On the other side, if you think of, you know, you do the early imaging and there's a severe malformation or cochlear nerve problem, then, you know, that might talk, you know, that those kids can have a seriously bad outcome with regards to speech and language acquisition. And so I think understanding that information for families is a different conversation than a child with connexin 26 normal anatomy and a, you know, severe loss that'll be a rock star with their cochlear implants. So I think, you know, for both of those reasons, you know, understanding whether there's an associated medical condition or having poor prognosis, this stuff is really, really valuable to know early on, not to identify it when you're, you know, 15 years of age and you've already been through a bunch of stuff. So I think everybody knows this. I'm going to sort of just move quickly here, but congenital hearing loss is probably 55, 45 now thought to be genetic. Of the non-genetic causes, far and away, CMV is by far the most common. Someone asked about CMV, and we'll talk about it a little bit later, but CMV is about 10% of all new hearing losses now, so really common. The syndromics are actually pretty unusual, and most of them you can tell outwardly if a child has that. A trip through the unit really puts you at risk for sensory neural hearing loss at a much higher rate than the well-born nursery, and we don't know what the real driving factors are in the NICU, although there's a bunch of theories. So when you think of the 100 kids that come in with that are identified with a new sensory neural hearing loss, about 10% of them are connexin, about 10% of them are CMV, about 30% of them have inner ear malformations. I'm going to repeat that: 30% have inner ear malformations. That means that inner ear malformations are the most common finding that we know of, at least today. So not unusual. So if a baby has a sensory neural loss, you have a pretty good chance of finding that, and there's still a lot of unknowns that are out there. If you're willing to do genetic testing, you're going to find a lot more. And there's at least 3 or 4 different places that are doing it now. But you know, oftentimes genetic testing can identify those cases that don't have inner ear malformations. If you're going to specifically look for connexin, and I think someone mentioned that on the discussion board, if you find a positive, I think it's valuable to reassure the family that, you know, there's unlikely to be other major medical things associated with it, and the prognosis is reasonably good. But if connexin testing turns up negative, then you really still don't have an answer for them. So it might not be, you know, useful just to do that. I like this picture from Walter Nance. This was published in the New England Journal now, probably 20 years ago. But the cool thing about this is that you see the cross section with scala tympani, scala vestibuli, and then scala media with all the beautiful structures of the organ of Corti. And you see each of those lines goes to each of those structures, and it shows a variety of genetic mutations that cause sensory neural hearing loss related to that structure. The cool thing about it is that when you look at this cross section, you know, there's lots and lots and lots of different mutations that result basically in sensory neural hearing loss. There's not going to be a single fix for each of these complex diseases. I think if hair cells are gone, then certainly I suspect that hair cell replenishment in some way someday is going to make a difference. But I think, you know, replacing a stria vascularis or a tectorial membrane or Reiser's membrane, those are not going to be quite quite so easy. So when a family asks you, should they hold off waiting for some sort of biologic therapy, I think the answer today is certainly no, at least in children. In adults, it might be more straightforward as we move on. We did a CMV study at UNC some years back, and when we looked at 110 kids, we also did Guthrie card. We got their Guthrie card, which was their perinatal blood spot, and looked for a CMV. That's actually where that 10% number came from. So you see here, 10% were CMV positive of 109 kids with newly identified sensory neural loss, and 60% of those were completely asymptomatic. So, you know, we oftentimes think of kids with CMV and they have a small head and they have cerebral calcifications and you know, problems with their liver and a variety of other things and sepsis. But lo and behold, 60% of these kids had absolutely no clinical CMV at all. And many of them progressed on to profound hearing loss. So CMV is certainly a major player. Many of them, almost all of them, have some MRI findings, and you can see these are a couple of examples. They can be pretty subtle, though. These are pretty drastic, but they can be subtle with just some small cerebral calcifications that might not be picked up, or periventricular white matter changes. So just be aware of the normal inner ear morphology and brain findings to potentially be CMV related. The trials are out there looking at ganciclovir show it to actually work. So ganciclovir actually works for CMV related hearing loss, certainly in terms of preventing progression. The problem is about almost 30% of the kids, I think, end up with some neutropenia that could potentially even be life-threatening. So it's not ready for prime time when it comes to using ganciclovir for CMV in kids that are completely asymptomatic other than hearing loss. But I think this is going to happen certainly in the next decade. I suspect there'll be another version of this drug that's much less toxic. So I think more to come here. Certainly a vaccine should be on the way too. The most common, of course, are the inner ear malformations. It's a beautiful example of EVA in Mondini. Let me see if I can point here. So you can see here's a CT scan of a Mondini, and you see an enlarged vestibular aqueduct directly next to the posterior canal. You see a somewhat reduced partitioning cochlea, and you compare that to normal here in the center. And then on the right here, what you see is an enlarged end lymphatic sac on an MRI. So you can see both MRI and CT can show enlarged vestibular aqueduct. There's been some discussion in the past that MRI was inappropriate because it couldn't show you EVA, but that's just not necessarily true. So MRI, I believe, is better than CT for most cases. The few cases that I actually think that CT is valuable, we'll talk about it here in a second. But again, this is a normal here, and here's a common cavity, just a single cyst. That's actually an unusual type of common cavity. Usually it's a much bigger sort of cochleovestibular cavity. This is Michel's aplasia that you can see here with a single small internal auditory canal and absolutely no inner ear. Remember from your embryology that the ossicles still form relatively normally except for the stapes footplate because they arise from different embryologic onlogs. So I find that fascinating. And then this is this view that you see here. This is really classic for charge association. When you see a small vestibule here, and then sort of this vestibular system that hasn't fully formed into semicircular canals, and then a somewhat flattened cochlea with a relatively narrow ISC. This combination of factors is very common in charge syndrome or charge association. There's also a high incidence of cochlear nerve disorders in those cases as well. And then this last one right here, I don't know, can anybody tell me what this malformation is here, if you can see it? How about a show of hands? What's that one called? All right, go for it, Erica. You're first.
Incomplete partition.
No. Okay, who's next? It actually is an incomplete partition, but what type?
Is that a cochlear saccular
Type
dysplasia?
3.
Type 3. Who
X-Link.
said?
Type 3.
Who said that?
Daniel.
Who said that? Daniel. There you go. Good, good. I'm going to owe you a beer someday when I see you. You're right. Yeah. So that's that's actually X-Link Stapes gusher. What you recognize from looking at it is certainly is incompletely partitioned, but there's no modulus. You see how the internal auditory canal goes directly into a cochlea that has a fair number of turns, but what you see is that there's no central bony, and there's no real partitioning. So they call that IP3. Liv Glue came up with that terminology. I don't know that I totally love it, but this is the case where you make a cochleostomy and CSF pours out, and then if you're not careful, when you put the electrode in the round window, it'll go right down the internal auditory canal if you're not careful. The other thing that's really interesting about this is that when you open this cochlea, excuse me, oftentimes once the CSF stops pouring out, you actually are looking at a completely normal cochlear nerve in the opening. So literally you see the entire nerve like you'd see in an acoustic tumor sitting in the cochleostomy. So it's certainly an unusual malformation. I've only done a few of them in my career. I would be really, really, really careful about getting too much into these. And I will tell you that, you know, there's a massive third window effect, as you guess too, because, you know, because of this wide communication with the internal auditory canal. Erica, you get partial credit because you called it incomplete partition. You know, the issue about head trauma is one that comes up year after year. It's certainly true that I think kids with EVA are prone to sudden drops in hearing. And whether it's head trauma related or not, I think it's sort of standard for us to talk to the families about trying to avoid that. I think it's a sort of a silly conversation when you have it, because, you know, then families ask, well, should we, you know, get the child fit with a helmet and all these other things? And I think the answer to that is no. They also ask about whether it's okay for them to fly, and I usually say yes. In the rare instance when you have a a relatively severe EVA, I've seen cases where the stapes actually has a hole in the foot plate, and they can intermittently leak CSF. So it's sort of interesting. The severe Mondini malformation, beware, and you might want to consider middle ear exploration in some of those cases to block it off, or to do, you know, if their hearing is profound, to do a cochlear implant. And at the same time, what I've done is I actually take out the stapes and pack the vestibule in those cases. Pretty unusual case. I have a video of that I could show you if maybe some other time. But those are things to think, you know, be aware of. So, and this is another sort of another MRI example of EVA. You can see just a beautifully large end lymphatic sac. The vestibule, you see the vestibule is somewhat large. So good example of EVA. Oh, actually, this is exactly that. So in some of the Mondini cases, you actually, you know, the inner ear can be pretty poorly formed. And you see this is a kid who had recurrent meningitis. And if you look here in the base of the stapes in the foot plate there, you can see what looks like almost like an arachnoid blister sticking up through that. Can you guys see that? Show of hands if you can see that. Yeah, okay, everybody can see it, good. Yeah, so that's a beautiful example actually. And you know, if you pull out that stapes, what you'll see is that there literally would be a through and through hole through the center of it. And so be that when you see EVA, poorly partitioned cochlea, and you know, really, I mean, literally like almost an unpartitioned cochlea, you should think about that. And when you do your cochleostomy at the time of cochlear implantation, CSF will pour out. Just be aware that you might need to address the oval window in the same setting as well. So gushers make up about 50% of EVA cases. So it's important to recognize that if you see someone who has a gusher, it's about 50-50. Sometimes I think the kids that have more fluctuations in their hearing are more likely to have a gusher. There was a child I dealt with some years ago who actually, the mom said that she had positional hearing, meaning that at night when they would go to bed and she'd lay down, she actually could take her hearing aids off and she was fine. And then when she'd sit up as the day went on, her hearing went down. Interestingly, she ended up with profound loss, so we took her to the operating room. and she hadn't had an ABR in some time, so we would do an ABR before we implanted her. And when we did the ABR with her laying on the operating room table, her hearing was normal. So we actually canceled the surgery. And when I saw the family back, that's when I asked them about positional hearing. We actually did a audiogram with her, after she laid on the ground for about 15 minutes versus, when she was standing up, and lo and behold, she fluctuated some 40 or 50 decibels in that time period. So if you have positional hearing, that's a red flag for a big gusher. She ultimately operated, had a big gusher, and she did fine. Let's just move forward a little more. I'm not going to belabor too much about EVA, except to say that about half of them have gushers, and many of them progress over time. I would say almost all of them progress over time. So even if they're not an implant candidate when you see them early on, give it time. Oftentimes they progress to one. The other thing is that what we also see is if someone has EVA on one side, usually the EVA side is worse than the non-EVA side, but both sides can progress over time. So they're probably due to a common genetic problem, but one ear is more affected than the other. So this is my medical evaluation sort of today for kids with sensory neural loss. Is obviously a history and physical exam, and then I do an MRI over CT almost in all children. There's a few reasons that I'll order a CT. One is if the internal auditory canal is very, very narrow. In that case, you really can't tell if the bony cochlear nerve canal is patent or not. And the separation of nerves on MRI is really limited. And so oftentimes a CT can help in some way there. If there's evidence of cochlear obstruction on MRI, so there's no T2 signal inside the cochlea, then I usually like to get a CT to see if there's some evidence of ossification rather than just being, say, fibrosis. That would go for both adults and children. If there's temporal bone pathology, I'll oftentimes get a CT to better understand that relationship. Although in many instances, without getting a CT, you can tell if it's just fluid. But if there's a tumor, if someone has von Hippel-Lindau or some weird thing, then usually an MRI and a CT are sort of both necessary. And then if you see that case like I showed you where the semicircular canals are absent, usually the facial nerve will take a very funky course. In those instances, I have cases where the facial nerve runs inferior to the stapes. And so in those cases, it's very much worthwhile getting a CT to see that before you go in there and get surprised. I often get an EKG to rule out Jervell and Lang-Nielsen. Those are usually profound cases, but I still get it. I would tell you that an eye exam should happen sometime in the first year, but it's not useful early on. So I usually tell the family it's worth getting it later in the first year to rule out Usher. Almost never autoimmune studies of any sort, except in adults that have progressive and fluctuating and steroid responsive hearing loss. And I save renal ultrasound basically to rule out branchiotorenal. So they usually have a conductive or something else pops up that drives me in that direction, like microtia, atresia, or whatnot. Renal ultrasound rarely. I'm not usually looking for protein in the urine or any of those other things. So the bottom line for me is the basic evaluation would be an MRI, an EKG. I usually like to get CMV testing if the Guthrie card is available. And I used to do a Coxon 26 in almost everybody, but I sort of told you the shortcomings of that is if it's positive, it's good, but if it's negative, it's not super helpful. So any question on that? MRI, EKG, CMV, and connection. Those are my big four. And those are all identifying many of the causes. If you want to send out genetic testing, if the connection is negative, then you can send it to Iowa or Mass Eye and Ear or one of those places and get more information. Daniel?
How do you test the CMV infection in a child? Which exam specific do you ask for?
Yeah, so in the perfect world, your newborn nursery would have sort of mandatory CMV screening, but that's not really cost effective. So if they're mandatory CMV screening, then they're looking for it in the urine. And in those cases, when it pops up at the urine, that means that they're actively shedding CMV, and that's highly likely that they have CMV disease. But that's usually not possible. And so I still think this is an evolution, but if you do PCR on the blood, that can turn up positive. Some say that it might miss as many as 40% of CMV cases if you're just looking for the blood, because if they're not viremic at the time, then you won't pick that up. So it's not perfect, but it does pick up a number of cases. So if you're able to get the heel stick blood spot and do PCR on that, that's reasonably good information regarding CMV infection.
Excellent, thank you.
Sure. Any other questions on evaluation? And then obviously ongoing at the same time, you have to think of amplification, cochlear implants. And so these things are all sort of fused together. If you remember that timeline that I showed you, it's critically important that you establish a very, very, very tight relationship with your audiology colleagues. If you don't do that, then this game will be no fun, I promise you. And so it's really, really important that you treat your audiology colleagues as professionals and recognize they bring an awful lot to the table. In fact, they oftentimes are better at communicating with the speech and language and pathologists and educationalists than we are. And so I think forming that team that's generally based off of strong audiology and otolaryngology and speech pathology together on the pediatric front is exceedingly important. And then you can add on sort of the ancillary stuff, the developmental pediatricians and whatnot. But really, audiology, otolaryngology, and speech are sort of your primary basis. Spoken language, if the family's after spoken language, then learning some sort of auditory verbal therapy is really important and can't be overemphasized. I think early implantation obviates a lot of the other issues. But if they're interested in sign language and whatnot, there's a variety of different options that you see there. And there still are a number of kids that end up total communicating for a variety of reasons, most common of which is being late identified and then late intervention. Okay, so here we go. Let's talk about auditory neuropathy. So I like this case because this is a kid I saw many years ago when I was at UNC, and I think it was very illustrative of sort of this whole auditory neuropathy business. This guy was 3 years old when I saw him. His name was Heath. I'm allowed to use his name because he and I are still buddies. And he had basically a very mild speech delay when I saw him at 3 years of age, but he showed up with a bilateral sudden sensory neural hearing loss, best we could tell. He could talk on the phone prior to this. He passed his newborn screening with otoacoustic emissions, normal pregnancy, full-term delivery, no hyperbilirubinemia, hypoxia, nothing. No family history, normal exam, no response to steroids by his primary doc for 21 days. He had an MRI that was read as normal in 2003, and he had an ABR that we performed. This wasn't my patient at the time, but it was thought to have responses on the right and no responses on the left. So profound hearing loss had responses on the right and no response on the left. So at the time, one of my partners, I'm going to try and get back here just so I don't bother you with this picture. Yeah, so at the time, one of my partners actually implanted Heath. He chose the right ear because there were responses on the right. So remember the ABR here showed responses on the right. And so Heath, who had just a mild speech delay ahead of time and could talk on the phone, had a sudden hearing loss. He got some steroids, it didn't help. And then he had an ABR that showed some responses on the right, none on the left. And so my colleague chose to implant him in the right ear, and he did almost nothing with the device. So he was implanted and literally did really poorly. And then I was asked to see him because he wasn't making any progress after, I think, about 16 months using the device. So this is a kid that should be a rock star, right? He would be a delayed onset hearing loss. He should be a kid that was just, and so when I saw him, he had this ABR. These are those responses that I showed you on the right. And what you recognize about this, or maybe you don't, is that this is an ABR done with clicks at very high intensity. You see they're done at 90 decibels. And when using single polarity clicks, it gives you this morphology. The single polarity is, say, in a condensation, and then invert it to a single polarity using a rarefaction, you basically get a mirror image. So look at these two ABR traces. If you move them up to the same line, you see they're basically mirroring each other. So the fact is that when you're changing polarities, you get a mirror image. And then when you drop the intensity down to 80 decibels from 90 decibels, what happens is the amplitude of this whole complex gets smaller, but it doesn't move out in latency. And then when you drop to 70, it essentially goes away. And then if you take and you clamp the sound tube, okay, so the sound tube that's going into the ear, the response completely goes away. So that tells you that when you take the stimulus away, but you're allowing the recording system to keep working, the entire thing goes away. So how do you interpret this? Well, an inverting response to differing polarities that goes away when you clamp the sound tube, okay, that's a cochlear microphonic. Does everybody understand that? So this is cochlear activation, and as you drop the intensity of the stimulus from 90 to 80, it gets smaller. If these were neural waves rather than a cochlear waves, the latency of this would move out. So the typical sort of findings of neural responses, as you drop the intensity of the stimulus, the response should increase in latency, and in this case it doesn't. So this finding is a cochlear microphonic, not a neural response. And as you and what you see is you also see no neural response here. So cochlear microphonic and no neural responses is diagnostic basically of auditory neuropathy. In 2003, we didn't know that all that well. At the time, I also got his CAT scan, and you can see that my partner did a great job getting the cochlear implant into the cochlea. And this is a pretty normal looking internal auditory canal, at least in size. Now, in retrospect, this is totally in retrospect. If I look here at the bony cochlear nerve canal, that looks a little tight to me, but I didn't think so back then. So no EABR, but had a cochlear microphonic. This is now, to me, it's auditory neuropathy. Wasn't so clear to me back then. So again, here's another example of auditory neuropathy. When you give high intensity clicks, you get a response. When you invert the polarity from rarefaction to condensation, it basically mirrors the image. So you can see how they're exactly mirrored, each of these little spikes. As you drop the intensity of either the condensation or rarefaction stimuli, it gets smaller, but it doesn't move out in latency, right? And so what you can see here is this is also auditory neuropathy, and you can see the same thing in both ears, right? Drop the intensity here, change the polarity, and then when you drop the intensity, it just gets smaller. So that's auditory neuropathy. And what do we know about auditory neuropathy is that when you think about it anatomically, it's basically hair cell activation is present. That's the cochlear microphonic, okay? But there's no neural waves being propagated. So lesion can be basically in the connection between the inner hair cell, the synapse, or the nerve. In all three of those cases, inner hair cell, synapse, or nerve, all three of those lesions can result in the exact same findings on ABR. So the epidemiology is interesting with NSD. It's probably also about 10% of the new hearing losses. Yeah, Daniel?
Do you have a specific study to analyze the site of the lesion in the auditory neuropathy?
Yeah, we'll get to that, but we'll talk about what my typical evaluation is, and then we'll talk about some of the research, and then I'll tell you where some of our shortcomings are. Okay, so we'll get to that. It's a good question.
Okay, thank you.
But basically, yeah. So we'll talk about it. Yeah, so it's about 10% of all new hearing losses or new permanent hearing losses, maybe 10% of those are profound. A trip through the NICU puts you at pretty high risk for that, and we know hyperbilirubinemia is just one of the real obvious causes. I just saw a kid this last week who has hyperbilirubinemia and auditory neuropathy. It can be both congenital and acquired. Of the genetic types of auditory neuropathy, otoferlin is far and away the most common of those. Those kids basically look like a Connexin 26 kid, except that their ABR has a large cochlear microphone with no waves. And so if you see basically a a child that's otherwise completely healthy with no other issues, and they have an auditory neuropathy diagnostic ABR, then think otoferlin, and that's very testable at any of those centers that I told you that do the genetic testing. And then there are syndromic versions as well, and you can see those here. Friedreich's ataxia and Charcot-Marie-Tooth are the biggies, as well as that BVVL I told you earlier, Brown-Violetto-Van Leer syndrome. So auditory neuropathy is interesting in that the hearing can be anywhere from normal to profound, and the speech perception is usually thought to be worse than the pure tone predicts, sort of what you would think about for a quote retrocochlear hearing loss. We know that listening and noise is very degraded. Gary Rance showed that in a beautiful study from Melbourne. And so most people think that when the nerves are present, that it basically results in a temporal processing disorder. The ABR, because it only shows a cochlear microphonic, is not useful for telling us what the thresholds are. And that's the thing that really holds the whole process up. So if you can't tell what the thresholds are, you can't fit them with hearing aids, and so you end up being pushed out. Because they're out, hair cells are still present. Usually OAEs are present in those cases. So a cochlear microphonic plus or minus acoustic emissions are usually present. And some people talk about fluctuating cases, but I think those are pretty unusual. There's a rare version. So these are just some cases to show you. And now that you're experts, you should recognize those. But here's a big, long, early potential in response to 90 decibel clicks. When you invert the stimulus, you see an inverted response here. And then as you drop the intensity of the stimulus, what you recognize is, for the most part, latency doesn't increase. So that's a cochlear microphonic. Same thing in the contralateral ear. Always remember that you have to do a no sound run. The no sound run is when you leave everything set up exactly the same way and you clamp that little red sound tube. The reason that you have to do that is because occasionally the other thing that will give you an inverting response is artifact. When you click in one direction and then you invert the click, sometimes you'll get an equal and opposite response as well. So you have to clamp the sound tube just to make sure that the electrodes still aren't recording an inverting response when the sound is cut off to the ear. In this particular case, you can see the behavioral audiogram when it was possible, and you see there's beautifully normal thresholds. And here's you see otoacoustic emissions that are present in both ears. So this is one of the 7% of kids with auditory neuropathy that can have normal, what appears to be normal thresholds. Hussein, question?
Yes, sorry. You want just very quickly tell the difference between rarefaction and condensation? Is it like the way the clicks are presented, or is it just like an audiology terminology?
Yes. Yeah, no, it's exact. Yeah, you're exactly right. So it's the way that the click is presented. It's basically about the polarity of the sound waves that are sent into the ear. It can either start with a positive or with a negative. So condensation starts one way and a rarefaction starts the opposite way, and it's how the sound is presented.
Okay, thank you.
Brandon, do you have a question?
Yes, sir. So I'm just trying to figure out how this patient is going to present to my office. I see a lot of pediatrics in my practice, and obviously, I'm just trying to think: is this kid going to show because of speech delay, or because they're going to maybe pass their OAEs? So what am I looking for on this patient?
Yeah, you're spot on. That's a perfect question. So if screening in your state with babies is done predominantly with otoacoustic emissions, then this baby will be missed.
That's what I was afraid of.
Yeah, this baby will be missed. And if you screen with automated ABR, which many states also do, then this baby will be found. And the question that's out there is, if you take children who are identified just like this one that I'm showing you with a normal behavioral audiogram and present otoacoustic emissions, Gary Rance would suggest that these kids still really tank in background noise. And so there's some evidence to suggest that this is not a normal ear, because it's not making your sort of your wave 1, wave 3, wave 5 type stuff.
Right.
But there's enough information getting through for them to detect thresholds.
Okay.
And then compare that with this kid here. Here's another case of auditory neuropathy. Again, Condensation gives you this. Rarefaction gives you the equal and opposite. The no sound run, where you clamp the sound tube and it goes away. When you drop the intensity, you see a smaller response. Present OAEs in both of these ears. This kid has profound. So it's interesting that the electrophys tells you that there's some problem in the conduction system to the inner ear, but they can have anywhere from normal thresholds to profound. And you might say, well, how the heck is that possible? It probably has to do with synchronization. If you think of the ABR, right? If the entire wave one of the ABR is a fully synchronized response of the entire auditory nerve that's triggered by the onset of sound. And so if all the nerves and whatnot are still there, but it's severely dysynchronous, then you can end up with the cochlea activating but not generating not generating normal neural waves. Contrast that with this case theoretically absent nerves, given the fact that it's so profound. So you can have a wide range of presentations. So Gary Rance in Melbourne, who's a really sharp guy, looked back at a group of kids fit with hearing aids. It used to be thought that kids with auditory neuropathy couldn't benefit from hearing aids, and he showed that about half kids get pretty good responses with hearing aids, but another half don't. So it's probably a pretty heterogeneous group of children out there with auditory neuropathy, some that gain benefit from hearing aids and some that don't. Whoops. So what do? We confirm the diagnosis with ABR. We make sure that they have that pattern that we talked about. You have to use single polarity clicks in the ABR. We MRI early, and I can show you maybe tonight or tomorrow about what some of the MRI findings are. So the issue is this: if you have a baby who fails a newborn screen, and then they come in and say it was a automated ABR screen, and they fail, you put them through and get an ABR, a diagnostic ABR, and it shows auditory neuropathy, but you don't know what their hearing threshold is. You can't actually fit them with hearing aids because you don't know what their hearing level is. And so oftentimes we sort of have to take a watch and wait approach in the early days until they're able to do behavioral testing. And then if their behavioral thresholds are normal, like that first one I showed you, we would just watch that and see how that child does. Consider repeating the ABR to see if it's actually normalized. And then if it's abnormal, we fit with amplification to see if they get benefit like Gary Rance showed. And then if they failed, with regards to developing speech and language how they're supposed to, then you can consider a cochlear implant. And so this sort of identifies the kids that would do poorly and advances them from observation to hearing aids and then up to cochlear implants. But it's through a little bit of a different paradigm than what we see. So when we look at the timeline for these kids, the difference is if you have auditory neuropathy is we can't always know what their thresholds are here early on. So what we do is we shift hearing aid fitting until behavioral threshold testing is possible. So that really pushes the timeline for cochlear implants out, usually well past the first year, some place into the second year. So this gives you some idea, and I'm going to wrap it up here in just the next couple of minutes. But in our population at UNC, when I was there, we were following over 250 kids with auditory neuropathy. It was about 10% of our group of kids. Most of them were bilateral. Beware the unilateral case because it's really associated with a cochlear nerve disorder. Almost all of them failed their newborn screen, but that's because in North Carolina we were using automated ABR rather than OAEs to screen. And then this is the key number. 60% of the kids that we saw had other disabilities, usually CP, visual loss, pervasive developmental disorder, a trip through the NICU. So beware of these kids that have spent time in the NICU. Auditory neuropathy is much more common. And many of them have soft tissue abnormalities on their MRIs. I just want to show you an example. Here's a child with Dandy-Walker syndrome. You see very little sulci and gyri, a bad, really degenerated cerebellum, and a sort of really not very pretty anatomy. Here's another example, brain with very little convolutions and surface. Here's those periventricular white matter changes that we oftentimes talk about. These can be common in kids that have hyperbilirubinemia exposure. And then just the last thing is that most of these kids do not have labyrinthine abnormalities. And so what you usually see is you see a child with a normal cochlea, normal vestibular system, and brain findings. And so sort of beware of that child. It's much less common to have labyrinthine anomalies than what we see in that 30% in kids with sensorineural loss. The other thing is about a quarter of the kids with auditory neuropathy that you see have cochlear nerve deficiency, and at least 2/3 or more of the kids that have cochlear nerve disorders will have an auditory neuropathy phenotype on their ABR. So, and as I said before, watch out for the kid with a unilateral auditory neuropathy because they almost always have cochlear nerve problems. I think I'll stop at this point and just open for questions for the last couple of minutes, and then we'll circle around and do more of this next time. Hossein?
I had a question in terms of that chart you showed, the diagram where some people benefited from hearing aids and some didn't. What's the relationship between that finding and prognosis with a cochlear implant? Like those who do not respond to the hearing aid fitting, are they also less likely to respond or do better with a cochlear implant, or vice versa? Or is there any relationship at all that you can predict?
Yeah, so I think you're getting really to the heat of the matter there. So I think it depends on what you're looking at from an auditory neuropathy perspective. If the child has normal anatomy, has a normal nerve, doesn't have severe brain problems, and has clear microphonic absent neural waves, fit with hearing aids, doesn't make progress, that child should, assuming good therapy and getting the device reasonably early, should do very, very well, almost like a normal child with sensorineural hearing loss. Compare that to a child who's spent time in the NICU, has severe hyperbilirubinemia and kernicterus, right? May have same sort of ABR pattern. That child may not do well, but it's not necessarily going to be because of their peripheral system. It's going to be more from their central system. And then compare that child with auditory neuropathy to a child with auditory neuropathy who has normal inner ear findings, but an absent cochlear nerve. All of those can look the same on ABR testing, right? So cochlear microphonic absent neural waves, and you compare each of the three of them, and they have very, very differing prognoses.
And if they're doing well with hearing aids, as you showed in that diagram, would you still then proceed with CI, or then obviously, or you
no.
You and then go from there? Okay.
Yeah. I think you just stay the course. If a child's making nice progress with using their hearing aids, then stay the course. Now, I will tell you that I've seen some sort of slow progression over time in many of these kids. So early on, they're fit with hearing aids. They're making nice progress, but their hearing is just not great for them to progress developmentally. And sometimes we end up going to a cochlear implant, despite the fact that they're making some progress. It's just not enough progress for them to support sort of good speech and language or even educational stuff down the road.
Thank you.
Sure. Other questions regarding this?
Yes, I have a question.
Oh, sorry.
Just to clarify on these patients, is it still just MRI, or is CT helpful, like you were showing on that CT you saw on your patient that you're friends with now?
Yeah. So, and I'll circle back on him, but interestingly, the reason he got a CT is because he had a cochlear implant and we weren't able to do an MRI on him. But I would still start with MRI, and if the MRI is stone cold normal, then I would not go on to CT. I would use the CT only if those 4 caveats I told you about: narrow internal auditory canal, some temporal bone pathology, cochlear obstruction, or absent semicircular canals.
Great, thank you.
Sure. Other questions or comments? There's some weird sound in the background here that I'm hearing. Oh, there we go.
Sorry, doctor. If you receive a child who did not do the neonatal screening in which you suspect a hearing loss, what study do you prefer to evaluate the cochlear function? An acoustic emission or a cochlear microphone?
Yeah, so I think it depends how old the child is. So if a child makes it until they're say they have some hearing, but they have hearing loss, the question becomes, what's the value of knowing that they have auditory neuropathy if they're not profoundly deaf? Because say they're 4 years old, they have a moderate hearing loss, and they're fit with hearing aids and they're making progress. Is there any value to go back and doing an ABR? And I don't necessarily feel like it makes a big difference. And so I think the real dilemma for kids with auditory neuropathy is that once we've had newborn screening and we want to move forward with the whole process, we're really sort of stuck in a place in that first year where we can't really move forward. But if they're 4 or 5 years old and they're gaining benefit from hearing aids and making good speech and language progress, I don't think that ABR is really necessary. I mean, you could do OAEs in the clinic just to know what you have, but I don't think sedating them or doing anything for an ABR is really worth it. Does that make sense?
Okay.
Yeah. The question that I also have.
Yes. I made this question.
Go ahead.
Sorry, I made this question because our electrophysiologist told us that the cochlear microphonic usually lasts more time during the life of the child than the autoacoustic emission. So maybe the autoacoustic emission is negative, and we are evaluating a child of 5 or 6 years, but he has an auditory neuropathy. Maybe with the cochlear microphonic we can detect it.
Yeah, there's no question that the OAEs go away before the cochlear microphonic is gone. The question is, what's the relevance of it in the management of the child? You know, if they're a baby, it's very important. But as they get older, really sort of the relevance of it becomes more academic than anything.
Yeah. Okay. Perfect. Thank you.
Sure. Any other questions? Okay. Well, listen, we'll stop here tonight and then we'll pick up here next time.